Also wenn wir uns da sehen, ne? Hi, and welcome to today's Pentax Live Academy with live transmission from University Hospital in Erlangen. My name is Timo Rath and I hold a professorship for endoscopy in our department, and today I'm joined by Dr. Francesco Vitali, who is a resident in our department and currently undergoing endoscopic training. And I'm also joined by Jessica Jacobs as a technical assistant, and she's the kind of nurse that you want to have on your side when it's out of the usual or complicated things to do. So with this, warm welcome to everyone out there. We are happy to have you here and honored to be able to perform this live transmission. For you, it's fairly simple out there. Just lay back, relax, make yourself comfortable. The work is on ours. And let's get straight into the first live case. Francesco, what can you tell us about the patient?
The first patient is a 62 years old patient without compliance. She had a colonoscopy because of a gastrointestinal ulcer, and after an Helicobacter pylori eradication, she still had bloody stools, and then we found a large spreading 30 millimeter big adenoma in rectum. It was resective with endoscopic mucosal resection, and the histology showed an high-grade intraepithelial neoplasia. And now the patient is with us for the surveillance coloscopy.
Well, yeah, thank you, Francesco. So it's a very straightforward case, at least in my view. High-grade dysplasia, 1 year before resected completely. It's now our surveillance colonoscopy that we do. And I'm showing you briefly the scope that we're using today for the first procedure. This is called the GI colonoscope. And it's a very smart invention. In this scope, we have at the very distal part an inflatable balloon integrated. And through a hand controller, I can inflate this balloon just by a simple push of a button. And when you inflate the balloon during withdrawal, what you achieve is a straightening of the colonic folds. And by this, you improve your visual field, and also you have a way more stable and controlled withdrawal. This turns out to be not only effective in terms of convenience of the examination, but this translates directly into finding more relevant lesions, as we'll hear in the break in between. So this is the scope that we're using, and you can see I can adjust the inflation status of the balloon to 3 different levels, and I also have a position which you see here is labeled with an A. This is an anchoring position. And once I do that, the balloon is even more inflated, meaning it's really anchored in the colon and thereby facilitating therapeutic maneuvers, such as complicated or advanced resections. So this is a scope that we're using, and while preparing the session, I already advanced the scope into the cecum. Oh, sorry. Microphone. This way. Okay. Yeah. You can clearly see COVID-19 is still affecting daily practice in endoscopy. All right. I hope everyone can understand me. So we are in the cecum in this patient. The balloon is deflated now. And for withdrawal of the scope, I will inflate the balloon so that you can appreciate how we can improve visualization. So this is right in the cecum. So what I do now, apart from this hand controller that you saw before, we can also activate the balloon by a simple push of a foot pedal. And as you can see now, the blue light is blinking, meaning the balloon will be inflated. And once this light is stable, the balloon is completely inflated. And we start the withdrawal. Now it's constantly on, the blue light, indicating that the balloon is inflated, and I do the withdrawal now. And one thing you will immediately realize when using the GI endoscope is that during withdrawal, you have to pull a little bit more, avoiding slippery of the folds. And as you can see already here, the folds are of course still there, but they're completely flattened now. And with this, I have a very good tip control. And at least in my eyes, tip control is one of the most critical parameters to be able to see the maximum during colonoscopy. So ideally, what you want to have is a stable, centralized position of the scope, where you can basically rotate the tip of the endoscope to see as much as possible of the mucosa. And also, as you see, gentle movements and have a very controlled withdrawal. Also, what you will immediately experience when you use a scope for the first time, peristaltic movements is reduced with this scope. As you can see here, we have almost zero movements in the bowel, which makes it easy to detect lesions in case they are there. We're now approaching the hepatic flexure. And as I'm taking out a little bit air, you see that the anatomy is collapsing in a way. And talking about air, or CO2, I should say, the beauty of this is when you inflate CO2 and have the balloon inflated, the air or CO2 is basically trapped, meaning you don't lose inflated CO2, leading to an enhanced and improved inflation of the colonic folds. And again, as you can see here, it's a very controlled withdrawal. So far, nothing of concern. And I can show you the opposite. What I'm doing now is I'm pushing the foot pedal again. As you can see here now, the orange light is blinking, meaning I'm deflating the balloon. And once I do that, you will appreciate how the anatomy slowly collapses. And this is exactly the effect of the balloon. The balloon is now away. As you see there, the distal parts are already collapsed because we have no entrapment of CO2 anymore. And as you can see here, also peristaltic starts again. So I think to me, this is really the masterpiece example. I'm inflating it again, push of a button or foot pedal. Blue light is blinking again. Once the balloon is fully inflated, we have a constant light. And then you can see how the colon unfolds again. I'm waiting a few more seconds until the balloon is completely inflated. It's now the case, and I'm continuing to slowly withdraw. And we are back in a very convenient position where we have a very good visualization, straightened or flattened folds, in combination with a very good insufflation because of air or CO2 entrapment with the balloon. And also, we all know that some colonoscopies turn out to be difficult colon anatomy, prior abdominal surgery. What you can also use this balloon for is performing de-looping in a complicated colonoscopy. Because when you have the balloon and anchor yourself in the colon, it's very easy to effectively de-loop the anatomy. And as you can see here, even at the flexures, I have a very controlled and precise withdrawal of the scope. And what I can also show you now is we are still in the mode where we have in the withdrawal phase. If I insufflate a little bit more air by just pushing the up button, we go into the anchoring position, meaning that the balloon is a little bit extra inflated. And when I then withdraw, the endoscope is basically fixed in the colon, thereby facilitating therapeutic procedures. Okay, there's a question coming in. Yep.
How do you control the inflation volume? There is some difference of the lumen diameter.
Yes, so it's an integrated into the pump is an automatic pressure control, meaning the balloon automatically adjusts to the colonic anatomy. At least in my view, ever since I used it, I had no situation where it's overinflated in a way because of the automatic pressure control inside the balloon. But my standard setting for withdrawal during screening or surveillance colonoscopy is inflation level of 3. And when I then feel areas of resistance, I go back to level 2 or even 1. But 3 is the setting that works in most cases. And as you can see here again, folds are almost completely absent. No huge bowel movements, very controlled withdrawal.
Another question from the floor.
Yep.
How does it feel for the patient?
Oh, no difference. Frankly, I'm not. I believe it's the endoscopist who chooses his technical gear when approaching the procedure, but so far never experienced, let's say, any side effects in terms of patient. This patient is frequent guest in our department, as Francesco told you before. 1 year ago, we performed EMR of a lateral spreading tumor. We used a regular scope there, but she's not. I have never had a patient who felt any differences through the use of balloon or no balloon. And talking about quality metrics, we've talked a lot about the technical gear that we're using. As you all are very well aware, the ADR is one of our benchmark criterions for quality in screening or surveillance colonoscopy. And then again, the ADR is a direct feature of withdrawal times. And I think it's very easy to imagine that through the controlled and slow withdrawal that the scope enables, we actually enhance the quality of our diagnostic procedures that we do. And if Francesco? As we see, it's a very controlled, constant, and slow withdrawal, where we can really look behind the single folds. So we're now approaching the sigma. Of course, we'll expect some sharp curves here, but as you can see also, we can nicely work around this with this GI colonoscope. So controlled withdrawal, and as I mentioned earlier, this ADR is directly related to withdrawal times. And as we'll see in the break, this directly translates into a significant increase of our ADR. But then again, at least in my mind, ADR is just a number. Of course, we have guideline criteria and thresholds that you should meet during your procedures. But in the end of the day, it's not about a number to increase, but it's about finding more clinical relevant lesions. This is the term I preferentially use. And this is indeed the case, as we'll see in the break. And as you can see here, sigma typically an anatomical position where we tend to have slippage of the scope, but here, as you can see, we have, again, a very controlled withdrawal of the scope. Bowel preparation is suboptimal, so she comes as an outpatient, so we have no direct control of this, but I think for today's intention and for the clinical purpose of the examination, good enough.
There are other questions from the floor.
Yes, please.
During EST, the user sometimes makes small movements of the scope. Does the balloon limit this?
Sorry, can you say it again?
During EST, the operator makes small movement of the scope.
Okay.
If the balloon hampers such movement.
Yeah, true, I agree. So the question is, apart from stabilizing the scope during a therapeutic intervention such as an ESD, can the centralizing of the scope actually be counterintuitive, that you don't have so much maneuverability of the scope? Agree, that can be the case, because realize when you inflate the balloon, the scope is centralized, and basically you have the optics right in the center. But then again, when you feel that you need more movements, you can easily deflate the balloon. So you can basically adjust it to the needs in that special situation. So when you have a situation where you want to have a stable position, you can do that easily with the balloon turned on. At the same time, when you need to advance more to the edges of a lesion, for example, you can easily deflate the balloon. So I think it offers both. We do see some hyperplastic lesions here during withdrawal so far. Oh, there is one lesion. You see that? And this is a good example because it's right on the folds. So we'll put it to the 5 or 6 o'clock position and we remove it. Cold snare. That's a tiny one.
Another question, Timo?
Yeah.
Do you reduce the pressure of the balloon or deflate the balloon if you have when you withdraw the scope?
No.
And then
so during the complete withdrawal phase, I was now at position 3, and this gave me a good stability of the scope. So whenever I feel that and can at the same time withdraw the scope, no need to adjust the pressure lever. If the balloon automatically loses some air, it fills up again automatically due to the pressure control. So we use now a cold snare, dedicated cold snare polypectomy snare. Hang on a second. Yeah, close it. Und durchziehen. Okay. So talking about colonoscopy and polypectomy, the scientific data is overwhelming on the superiority of cold snare polypectomy. This is what we do in all lesions up to 1 centimeter, sometimes even bigger. And this is the new standard. The snare that we just used was a dedicated cold snare. We also have a hybrid snare on the table. I'm showing you at the end of procedure what kind of devices you should have on the table when approaching polypectomy. So what we typically do when cold snaring is the lesion or the polyp remains on the resection site, and you can just suck it through through the working channel of your scope. Really a game changer during colonoscopy. All right, we are almost done. Now we are in the rectum. Of course, before complete withdrawal of the scope, we deflate the balloon, simple push of a button. And then we slowly...
Another question, you can deflate and inflate the balloon. You can decide how much.
Yep.
How much are you normally using?
Yep. So my standard is 3. This is the resection site from the prior LST removal here, completely unremarkable. No residuum, no recurrence, so all is good. Typically I use setting 3, but if I feel that during the withdrawal I have some resistance, I change to 2, and if there is continues to be resistance, I change to 1. One thing I would like to show you, when talking about screening, surveillance colonoscopy, it's always good to have the right equipment right on your table. So what we typically have when we approach patients for polypectomy, we of course have something to inject the mucosa. There we basically use dye, and then a variety of snares. The snares that you just saw was a dedicated cold snare polypectomy. Now there are very good snares out there that are hybrid snares, compacted wire technology, which you can use for cold snare and also for hot snare at the same time. And one thing I'm very fascinated about is this: whenever you go into procedures with advanced resections, it's advisable to also have coagulation devices on your site. And this is one of the coagulation devices. It's called the hemostat cap. So it's basically a small forceps. And when I open it, you see that it is indeed really small. Can you see that? Yeah, maybe a little more zoom. There you go. And the beauty about this hemostat cap is it is bipolar, meaning all the electrosurgical current that you apply is concentrated in between those two blades. What does this mean, bipolar? That means that you don't cause deep thermal injury. So you basically protect the deeper layers of the intestinal wall while having the surgical content concentrated in between those blades. And how I use this device most often is that with open cups, you approach a bleeding site after intensive EMR or ESD, and you just press it onto the tissue. And that is in most cases good enough to stop the bleeding. Because with the open cups and the bipolar nature of this device, the current flows in between those two forceps. Of course, you can also grasp. If it's a bigger vessel, you can also close it, Jesse. You can also close it and carefully grasp the tissue. But typically, open cups, putting that onto the lesion, and then apply electrosurgical current is good enough. Also to me, with this bipolar nature, one of the game changers in coagulation device. So with this, we are ready with the first case, and we'll have a short tutorial on the technologies that we're using, and I'm trying to show you the benefits. So I'll just change the room real quick, and we'll be back in a second. 15, 14. Das ist der Countdown, der zählt, ne? All right, so back again. Well, you've seen the GI colonoscope now, in this break, 15 minutes, I'm trying to show you some of the devices that I think are very useful for delivering the right quality during colonoscopy. And let's start with this video. I'm pretty sure some of you know this gentleman. This is Professor Ralf Kieslich from Wiesbaden, and he did some landmark studies on the GI endoscope. And you see here again the principle of the scope. You have an inflatable balloon, automatic pressure control, and as you see in Professor Kieslich's video during withdrawal, it's basically the same as what you've seen before. We have a straightening and flattening of the folds, and this again then leads to the situation that we have a higher exposure of the mucosal surface and thereby can detect more. And in a landmark paper published in 2019, you also see the difference in withdrawal with and without balloon. On the left-hand side, you see the deflated balloon in the same patient. On the right-hand side, you see the situation where we do withdrawal with the inflated balloon. As you can see, it's really a tremendous difference between those two videos. And I think it's very easy to appreciate that we have a higher exposure of the mucosal surface, potentially leading to enhanced detection. And this is the theory behind. We want to see more of the mucosa and thereby potentially detect more lesions. And that this indeed holds true has been shown in, at least to me, one of the most important studies of the last year in terms of how to improve adenoma detection rates. Large study, more than 1,000 patients screened and randomized, so an international multi-center prospective randomized study. 1,000 patients randomized to receive either standard colonoscopy or GI-assisted, balloon-assisted colonoscopy. So those patients were randomized, and patients were undergoing screening, surveillance colonoscopy, or endoscopy due to positive FOBT or change in bowel habits. So this is basically the setup of this trial. And what you can see immediately and appreciate, I think, with these high numbers, 1,000 patients randomized, these were two cohorts or two arms of the study that were, first of all, very well balanced. So no differences in epidemiologic characteristics such as age and gender. And also in terms of procedural characteristic, bowel preparation score, indication for colonoscopy, virtually no difference between those two groups. And also 11 centers participated in that study. Experienced and less experienced endoscopists both performed the procedures, completely balanced between the two arms. And also the procedure times. It's a question that frequently arises with the balloon. Do I have any side effects in terms of insertion of the scope? No, you don't. You can still intubate the ileocecal valve with the same efficacy. And also insertion time is unchanged as compared to standard colonoscopy. So really the insertion phase is identical. The difference is the straightening and flattening of the folds during withdrawal. However, this does not translate into a situation where we have prolonged examination. You can still do the colonoscopy in the same amount of time that you perform the endoscopy anyway. And now if we look at these results, it really is a tremendous difference. In that study, baseline ADR, standard colonoscopy, 37.5%, and a dramatic increase by more than 10% in the GI arm. So this is really a fantastic result. And to me, even coming from a very high baseline ADR, we still have a further increase by almost 11% when using GI. And also, in line with this, we detect more polyps per patient, more adenomas per patient, adenoma number per patient as a mean from 0.7 increased to 1 adenoma on the GI endoscopy. But as I said during the first case, ADR is basically just a number. It's an important quality criterion, but in the end, what does it mean? And you see that in the following data very nicely. Initially, I thought the GI endoscope might help in finding small or even diminutive lesions, but with here the size chart, you see that it's completely different. And basically what you detect additionally with the GI endoscope is not only diminutive lesions, but it's also large lesions. Look at this, 62% more detection of large lesions, large adenomas, I should say, with the GI endoscope as compared to the standard endoscopy. And these are really clinical relevant lesion is shown in the following rows. Advanced adenomas, 62% increase under GI colonoscopy as compared to standard colonoscopy. Look at serrated lesions, SSAs, SSPs, 500% or more increase detection with the GI endoscope. So really, it's not about only increasing the ADR, but finding more clinical relevant lesions such as large adenomas, advanced adenomas, serrated lesions. So to summarize the aspect of GI colonoscopy, I think we can say the following, and a lot of that you've seen during the case and the videos shown here. We have a straightening and flattening of colonic folds, and with that we can improve our detection and find more clinical relevant lesion. And this is on the basis on very or rock solid data that we know that this principle works efficiently. And I think, as you've seen also during the first case, we have a very controlled withdrawal, reduced slippage, especially at difficult anatomic positions. Think about the hepatic flexure, the splenic flexure, or the whole sigmoid colon. We can achieve an endoscope stabilization through the anchoring function and thereby facilitate our therapeutic maneuvers, interventions. However, the balloon is not fixed. You can also deflate it if you want to have more manual control of the scope position. And also, not to underestimate, we all know, let's say 5 to 7% of colonoscopies, if your referral center, are very difficult, and especially prior abdominal surgery. And there you can also use the anchoring function of the balloon for efficient delooping in order to be efficient with difficult colonoscopies. So looking at these pictures, I think we have covered the right side. We now learned about a new scope that leads to higher exposure of the mucosal surface and thereby enhances detection. How about if we combine this with another approach, which is artificial intelligence? And this is what the second part is about. Artificial intelligence is basically everywhere now. And I'm very excited to show you very first data that led to the development of a completely new system that is after a very fast development phase now already available. And this is called the Pentax Discovery System. So in a way, in a tandem approach between software engineers from Pentax and clinical partners, among them our department, we generated a new DCNN, Deep Convolutional Neural Network. And when you establish such a system, the major task is to have a sufficient amount of images, because you need to develop or train a system. And for that, we collected 116,000 images from routine colonoscopies. And every single image was manually annotated by 5 expert endoscopists, meaning you have to show the computer where the polyp in the picture is hidden. And by that, he learns to recognize these polyps by itself. And of course, these annotations were treated as the gold standard and then used to train the DCNN. So this was the training set. And it's really something that was developed from scratch. And as you can see here, this is a prototype still in one of the latest stages of development. And you see in the back a software engineer in the facility testing for functionality. And now it's not a prototype anymore, but serious production is already is begun. The product is available yet, and you will see that during the second part, during the second live case. So when we tested the system before launch, we first had generated ex vivo data. How does this system perform on ex vivo images, still images, or endoscopy videos? So for that, we had tested more than 15,000 video frames. A little bit more than 50% of these video frames contained actually polyps. And those were not the polyps that are easy to recognize, but among them 50% of lesions that were kind of challenging, flat lesions as defined by the Paris classification 2A to B. And again, pictures, images, videos collected during routine colonoscopy. As you've seen before, not every bowel is perfectly prepped. And these are exactly the cases that we want to challenge the system with, because this is then the only realistic scenario. Kind of a challenge for every system, because feces might be realized as a false positive. But when we have this test set of more than 15,000 video frames analyzed by the system, we see a very convincing sensitivity of 90% for correct detection, and at the same time localization in the screen. So the system not only detects the lesion in the frame, but also localizes it to the screen, so by applying a bounding box to the screen. And at the same time, although very sensitive, highly specific with 80% specificity, and diagnostic overall performance was with an area under the curve of 92%. So really a system that works beautifully ex vivo. So based on this, we went into a very first and pilot in vivo study. 36 or 40 patients included, presenting here in our department for mainly screening or surveillance colonoscopies or changes in bowel habit. So what we do, we challenge these patients with a tandem colonoscopy. Now what is this? This means tandem colonoscopy means we have a first inspection with standard forward view, and then do a second inspection of every colonic segment with the Discovery AI system. Colonic segments defined as cecum ascending colon, transverse colon, descending colon, and sigmoid colon. And of course, in every segment, we recorded the number of polyps, the size of the polyps, the morphology of the polyps, and also the withdrawal times. And clearly, we all removed all polyps in separate containers to have histology available. What you can see at the table, withdrawal times between first inspection with standard endoscope and second inspection AI-assisted withdrawal times were virtually identical. Although we were during withdrawal at the fast site, we'll come to that in a second. And what we then see is something I'm very excited about. After first inspection, we had 28 polyps in those 36 patients. However, if we did the second inspection, now with the help of Discovery AI, this increased to 52 polyps detected, meaning we had an increase of 86%, highly significant. This translates into an increase in polyp detection rate from 36% to 50%. Looking only at adenomas, something similar, 18 adenomas during first inspection, standard endoscope, with the help of AI, increased to 29 adenomas, translating into an increase of 61%, or if you wish, increase in baseline ADR from 25% to 33% in those very first patients. And on the right-hand side, you see the table showing you the histologic and morphologic details of the additionally found lesions. So 11 adenomas additionally found. Size-wise, either diminutive or 5 to 10 millimeters, so small. Fairly evenly distributed throughout the colon. The majority were containing low-grade intraepithelial neoplasia, so nothing to worry about. But, and this is important, among those very few patients, only 36 patients, 3 additional SSAs found with Discovery. And remarkably, those were of 2B morphology, 2A to B morphology, very subtle lesions, even during second withdrawal, not noticeable with the naked eye, but only to be detected because of the bounding box that AI put on the lesions. So with this very first data in this exploratory pilot cohort, I think the picture turns out to be the same as with GI. We do find more lesions, and these lesions are clinical relevant. And you will see that now during the live stream, but as a first glimpse, this is how the system works in vivo. As you can see here, withdrawal phase, during a routine colonoscopy, and there a polyp is detected immediately once it appears on the screen. It is detected by the system. Fair enough, the first video, that is an easy polyp. Now, if you look at the second video here, this is more a challenging lesion, right? Easy to slip through. 2B morphology, looks like an SSA, but precisely demarcated and highlighted through the discovery system. And then here, another case, challenging because of insufficient bowel prep. However, feces is left untouched with the system, but what you realize here is a small polyp hidden in between this residual stool. So really one of the challenging cases, but still precisely realized with this new AI system. So with this, I think we set the stage for the second case. So we'll see in a very few seconds again in the procedure room. Okay, we're back. Okay. So the gentleman that you see over here is Professor Atreya, one of our attending physicians. And while we had some fun in the office learning about GI and artificial intelligence, Professor Atreya was kind enough to advance the scope into the CECM next patient. Raja, I told you you won't be online, we won't hear you, but it was fake news. So
someone has to work in the unit. So,
so he got punked. Do you want to say something to the audience, or?
So all the best. Enjoy the second part of this really lovely session and demonstration.
Okay. You want to say hi to your family or something?
No, absolutely. They're watching, and it will be as great as the first part of the session.
Okay. So thank you. Credits now and kudos to the team. And I mean, we have good fun, but without a great team working behind the scenes, everything is nothing. So with that, thank you.
It was my pleasure. Thank you.
All right. All right. It's admirable, Raja. Kind of, though you really have stand-up qualities, right? You didn't know that you will be online, but you handled it very well. I'm impressed.
It was an excellent scope, and it was very easy to go out.
All right. See you. So, same scenario, and we're back in the CECM. Balloon is, I'll show you the control, is deflated. First thing to do is activate the balloon. And And as you can see, it's blinking, so air insufflation is currently going. And you can insufflate the air either by pushing the button on the hand control or by using the foot pedal. And as you can see, I'm using pressure setting 3. And this is basically my standard. So far, same as before, same old, but now we have something different. The image that you're seeing now, the endoscopic image, is from our discovery system. So the discovery system is a separate monitor. It's already available, and when you install that in your department, it's a second monitor, 32-inch. So I'm looking at this discovery while you see the direct transfer of the endoscopic image linked with AI. Mm-hmm. And as you can see here on the 11 o'clock position, we have some feces left, but it's not recognized with discovery, and this is exactly what you want to have. False positive rate as low as possible. Now we start with the withdrawal.
Een fall voorstellen.
Sorry?
Een fall voorstellen.
Oh yeah. Oh, right. Francesco reminded me that he has some slides prepared to introduce with the next case. So Francesco, please, while we work here.
So, the next patient is a 57 years old female which presented in the emergency room with vertigo and melena, bloody stools. The hemoglobin was 6.7. He had no allergens, just arterial hypertension. And then we performed esophagogastroscopy and colonoscopy. And then we found many diminutive polyps in this cecum and in the sigmoid colon. And now we are here to perform the follow-up colonoscopy to exclude adenoma residual, because in the histology we show low-grade EAN.
Right.
Thank you.
Yeah. Yeah, thank you, Francesco. So really, these are the patients, similar as the first patients, where you want to deliver the maximum quality screening or surveillance colonoscopies. Because what we all fear is, as you know, interval cancers, right? A cancer arising in between two endoscopies that makes your quality look very poor. So I'm withdrawing now, ileocecal valve, 7 to 9 o'clock position. Some solid stool residuals, but not recognized by the position. And if you now watch my right hand, even if I pull a little bit on the scope, it doesn't slip back. I think you can nicely see that now, how controlled the withdrawal is with the GI, even in the second patient. So, and you don't need to be too afraid of also doing some insertion maneuvers with the balloon inflated, as I did now, so you don't cause any harm. So again, very good air insufflation due to the fact that CO2 or air is entrapped in front of the balloon. And as you've all seen now, also during the first case, very easy to have controlled withdrawal, very good and precise tip control. And so again here I lost a little bit the overview at the hepatic flexure, but still, even with the balloon inflated, I can reinsert the scope. So no problem with that. And you don't hear that, but we have a visual polyp detection. A bounding box is laid over all polyps present, but you can also have an acoustic signal in addition, which gives you an acoustic signal. And to me, this is one of the major benefits that you can turn on an acoustic signal. Why that? Because we all know also analyzed in different studies, throughout the day everyone develops some level of I would say fatigue or something. This is just natural. The more procedures you do in the second part of the day, you automatically get a little bit tired, and this is, I think, daily life in every endoscopy unit. People enter the room, ask you questions, so you lose a little bit of focus for some seconds. And these are the moments where the acoustic signal is really helpful, because it gives you an acoustic alert in order not to miss lesions, or it helps to maintain focus when in the second part of the day you start to develop some degree of inattention. It's a psychology phenomenon, and psychologists call that inattention blindness. So although we are physically present and following the procedure, we have, although we watch the picture, we can develop something called inattention blindness. And this is exactly the scenario that I was just talking about. We are in the room, we're looking at the screen, but for some reason, either someone entering the room or fatigue, we are not 100% with the procedure. So our eyes don't process what they see on the screen. And this is where an alert signal, an acoustic signal, helps you to maintain focus and to maintain attention. And as you see here, it's beautifully inflated. Of course, we still have folds there, but they're completely flattened. And even if I now provide some suction to take out the remaining fluid, it remains unfolded, the colon, due to CO2 air trapping in the balloon. So here again, flexure. Let's see how slow and nicely we can work around ourselves this flexure, and how good we can look into the flexure through controlled withdrawal with the balloon. Here, tiny spots, not detected by AI, which is important. Frankly, false positives are there. Of course, it's always a balance between sensitivity, so we have a highly sensitive system, and of course with a highly sensitive system you won't be 100% specific. This is just clear. In the pilot study, where you've just seen the data in the break, we had a mean of 1.5 false positive hits per patient, which to me is not much of a big deal. And this is just my personal opinion, but I would rather have a highly sensitive system than making compromises, rather having a highly system due to the fact that we also will have false positives to some degree. If you imagine the other scenario, if you turn down the sensitivity, you might have less false positives, but this again might lead to the fact that you miss more relevant lesions. And in the end, if it's a false positives, if we get a signal here from an artifact, a bubble or a feces, it's no big deal. You just look on the screen and decide within milliseconds whether it's a real polyp, adenoma or not. So really, my preference here is having a highly sensitive system rather than losing or overlooking relevant lesions. But here you see all those tiny residuals really don't possess a challenge to the system. No positive signals here. Now I'm withdrawing a little bit faster because I know I have a sensitive system in the back also analyzing the pictures. Okay, a little bit loss of focus, even inflated balloon. Here's some mucus, again, not detected, which is exactly what you want to have. Further withdrawal. But at difficult sites, you can also reinsert with balloon inflated. So, Francesco, anything from the audience so far? Or?
No question.
No? Okay. Okay. Everyone is convinced it's a good system. Okay, that's good. Here, challenging, detected. Can be two things. If anything, it's hyperplastic lesions. Nothing to worry about. So we did a lot of studies in the past about differentiation between adenoma, hyperplastic polyps, through the means of HD white light or optical filter technologies such as optical enhancement, and we know that we can accurately differentiate between hyperplastic lesions and real precursor lesions, adenomas, with a little bit of experience, and once your eye is trained to that. So this was nothing to be concerned of, no need to remove this.
We have a question from the audience.
Yep, all right.
Does provide the system when a polyp is detective a sound?
Yes. Yes, you can manually adjust it. Actually, you have different sounds to choose from. Similar to your smartphone, you can you can adjust the settings to the alert signal that is most convenient to your eyes. You can turn that on. You can also turn it off. This is just a matter of personal preference, whether you want to have the sound on or not. We are already in the rectum. So far, no lesions.
I should encourage the audience to ask questions.
Anything from the audience? Okay. Before we finish, I just reinsert a little bit to again examine the sigmoid colon, because I felt there I had some areas that remain blind spots to my eye. Oh, there's something. Yep. All right. Yeah, it's automatically detected. Good that we reinsert it. So here's a polyp.
Timo, can you combine the RE function with the GI function and the navigation function?
The GI function with the AI function?
The detection, the polyp detection with the AE, with the navigation and the GI function.
Oh yeah, of course. Yeah. It's possible. And in terms of AI, really I'm fascinated by that system, but it's clear in terms of AI in general, we're at the very early stages, right? So far we have systems that enhance our detecting capabilities. In the future, clearly we want systems that provide us an output differentiating the lesions. So when I look at a lesion, that automatically tells me on whether it's a hyperplastic lesion, an adenoma, a serrated lesion, more advanced lesions, something to have infiltration depth. This is certainly something that we will see in the future.
And Timo, do you use eye scan during withdrawal?
Yes. So our standard setting. So iScan 1 means we have a surface enhancement, and it's proven through various studies that we enhance detection by simply turning on iScan 1. So this is our standard mode for withdrawal, and I highly recommend using that as your default mode, because it's proven across studies that it's superior. Polyp is a little bit challenging because it's right here in the angle. So there we go. How much is difficult anatomic landmark here. So ideally, when you do cold snare polypectomy, you want to have the lesion ideally at the 5 o'clock position. Obviously, not always possible, as in this case, but we'll manage. Okay, this is mucus. Okay, now too. Okay, we take another look. Otherwise, we will change patient position. Anything else from the audience? We're a little bit over time already, so I apologize.
Will it possible to upgrade the system in the future?
Oh, yeah. I'm looking to Pentax people over here. Yes. So, as I said, the overall aim will be not to have a system purely detecting, but the next step is certainly characterization. But as I've said initially, characterization, you basically start from scratch again. You need a lot of images to collect, first of all. And then even more challenging, you need accurate histology for every polyp that is in the picture. So this is really something that requires some very careful data collection across centers, but the moment will come, of course. Once you have that integrated, you have basically the perfect combination between increased exposure of the mucosal surface by devices such as the GI, increased detection with AI, and then at the same time also characterization. And looking now at this, so in the meantime I switched the balloon off. I had it already deflated because we were approaching the rectum. The mucosa is now better inflated, but I don't see any lesion again. So maybe it was just an artifact, mucus. Oh, there. Is it this one? It's mucus. It's mucus, okay? So this is mucus, not a polyp. But there, this one, that looks like it. Okay, very difficult because it's automatically hides in between the folds. So, all right, I would suggest we're over time, so we don't want to hold you up too long. So we change patient position to remove that. Any questions in between, Rath? Otherwise,
No question.
I can already Yeah. Okay. Yeah. 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 Okay. So we got it. With that, this is everything we wanted to show you. Again, thanks for joining. Thanks to the whole team here supporting the Life Academy. This is not the end, so there are future sessions, especially on GI. Check social media, check the websites. I know that there are upcoming series in November and September. So stay tuned, join for the next Life Academy, next sessions, and hope to see you soon. Thank you.